Welcome back, everyone. Let's jump right into Part 7 of the Decode Healthcare with Harshal Explainer series. Today, we're putting on our expert clinical auditor hats for a totally practical masterclass in clinical case studies. We're going to decode step-by-step debridement coding, look at exactly how to perfectly document both initial and follow-up encounters, and most importantly, I'm going to show you how to defend your claims against the absolute strictest 2026 audits.
Look, there is a massive financial risk hiding right in plain sight here. In 2026, debridement coding is no longer just about picking the correct CPT code out of a list. The audit focus has dramatically shifted. You could pick the absolute perfect code, but if you omit a single line in your chart documenting measurable clinical progress, you are staring down an automatic, totally avoidable, and very costly audit recoupment. As compliance gatekeepers, we simply cannot afford to let one missing sentence undo all of our hard work.
So here is our exact roadmap for today. We'll kick things off with our 5-step decoding framework, define the playing field, break down an initial encounter, jump forward to a 2-week follow-up, run a quick audit drill, and finally lock in the golden rules for 2026.
All right, let's get into Section 1, the 5-step decoding framework. When we're evaluating raw clinical notes, we can't just guess. We need a rock-solid, highly structured approach to translate abstract compliance rules into practical, audit-proof coding. Think of this as your ultimate clinical storytelling checklist. First up, establish medical necessity. Did this patient truly, objectively need debridement today? Second, review the actual action. What exactly did the provider do, and what specific instruments were used? Third, select the correct CPT based on the depth and area. Fourth, validate documentation to make sure every single required element is actually in the text. And fifth, show the outcome. How did the patient respond, and what is the updated plan? This is the exact lens through which an auditor is going to view your chart.
Moving right along to Section 2, defining the playing field between selective and excisional. Before we tear into a real case, we have to get our clinical vocabulary straight so we know exactly what tissue is being removed. On one side, we have complex wounds, ranging from pressure sores to diabetic ulcers. On the other side, we have the distinct methods used to treat them: surgical, mechanical, enzymatic, autolytic, and biological. What you really need to understand here is that the provider's chosen instrument and specific technique dictate absolutely everything about our code selection. Simple wound irrigation or wet-to-dry dressings, those are mechanical. They are definitely not coded the same as a physician aggressively using a scalpel or a curette.
So, selective debridement, that's basically just cleaning up the wound surface by removing non-viable, dead tissue. However, and this is an absolutely crucial distinction, if a provider takes a curette and cuts into deeper, healthy structures like subcutaneous fat, it is no longer the selective code 97597. The very moment we excise subcutaneous fat or deeper, we escalate straight to the surgical CPT 11042 or higher.
Okay, let's see this in action. Section 3, the initial encounter and baseline presentation.
Let's put Step 1 of our framework to the test with a real-world chart. Picture this. Our baseline patient is a 68-year-old diabetic presenting with a chronic right plantar foot ulcer. It's been there for 6 weeks and is totally failing standard conservative care. Our baseline measurements are 4.0 centimeters by 3.0 centimeters with a depth of 0.4 centimeters. The provider notes moderate drainage, slough, and critically, that necrotic subcutaneous fat was surgically excised using a curette. Medical necessity is clearly established right here, because that devitalized tissue is actively impairing healing and driving up the infection risk.
Time for some quick CPT math. Our surface area is 4.0 multiplied by 3.0, which gives us 12 square centimeters. Because the provider excised subcutaneous fat, we immediately look at code 11042. Now that code covers the first 20 square centimeters of subcutaneous excisional debridement. Since our total area of 12 is less than 20, we select CPT 11042. And guess what? We need absolutely no add-on codes. The math perfectly, undeniably supports the primary procedure code.
Now let's fast forward a bit. Section 4, the 2-week follow-up and how we defend repeat procedures. Follow-up encounters. This is exactly where the vast majority of compliance failures actually happen, and it brings us to the most critical question every single 2026 auditor is going to ask you. What is the distinct medical necessity for performing this procedure again today? Just writing continued debridement in the chart? Yeah, that is no longer going to cut it. Every single session needs its own unique justification.
To effectively shut down that auditor's question, take a look at this beautifully compliant 2-week follow-up note. The provider documented that the wound size reduced to 3.2 by 2.5 centimeters. The drainage decreased and healthy granulation tissue actually increased. However, there was still 9 square centimeters of necrotic subcutaneous tissue remaining, which had to be debrided. The treatment plan was then updated with offloading and advanced dressings. This perfectly, 100% justifies repeating CPT 11042. We have measurable size reduction proving the treatment actually works, clear ongoing necessity for the remaining necrosis, and a totally actively managed care plan.
Which brings us to Section 5. Let's run a quick audit drill and look at a negative control.
We've seen what a gold standard note looks like. Now let's see what happens when documentation just completely falls apart. Imagine a non-compliant note that simply states, continued routine maintenance care. It's just copy-pasted text from the previous visit with absolutely zero new measurements. When you compare that to our compliant note showing exact measurable reduction, the risk difference is staggering. Doing repeat debridements without clinical evidence of improvement raises massive red flags. If your notes are just cloned and lack specific progress markers, you are practically begging for denials, claim recoupments, and prepayment audit flags. You have to prove progress independently every time.
All right, let's bring it all home with Section 6, our golden rules for 2026.
If you want to absolutely bulletproof your claims going forward, you need to lock in these 3 golden rules. Number 1, prove medical necessity. Every single session has to tell its own unique clinical story. Never, ever assume the auditor just knows why the patient is there. Number 2, accurate math. Rely on correct depth-based CPT selection and perfectly calculated square centimeters. And number 3, document measurable patient progress. Avoid that repeat routine care phrasing like the plague. Record the exact changes in wound size and tissue health to prove without a doubt that your interventions are actually working.
And that wraps up our deep dive for today. Remember, as compliance gatekeepers, your documentation is literally the only shield you have out there. But hey, this journey isn't over. Up next in Part 8, we are going to tackle the really complex CMS policy shifts surrounding skin substitutes in 2026, plus the prerequisite rules for wound bed readiness. Until then, I want to leave you with this final thought. If your follow-up documentation can't definitively answer why the procedure had to happen today, are you truly ready for a 2026 audit? Think about it. Thanks so much for joining me on this explainer, and I'll see you in the next one.